today I will be speaking on diabetic cystopathy diagnosis and management. So what is diabetic cystopathy? It is a progressive spectrum of lower urinary tract symptoms arising from hyperglycemia induced damage. Primary features, there is reduced bladder sensation because of afferent nerve damage, increased capacity because of chronic overdistension, and impaired contractility because of the efferent and myogenic failure. So it is mainly because of impact of hyperglycemia on the nerves which are supplying the lower urinary tract, particularly the urinary bladder. So the initial view was that in 1976 that there is a classic diabetic cystopathy where there is a sensory loss, there is increased capacity, and there poor emptying. The classical neurogenic bladder which we describe in individuals who are having long-standing diabetes and old age. But this is a static end-stage condition which is caused by autonomic neuropathy. But initially, the majority of people who are presenting with initial symptomatic features which are related to urgency and frequency and which are also part of this spectrum of diabetic cystopathy. So if we see this data of 1995 study of Kaplan of 182 diabetic patients, 10% they are having detrusal areflexia, 55% they are having overactivity, which contradicts the concept of neurogenic bladder or paralyzed bladder, and only 23% they are having classic cystopathy. Up to 93% of diabetic patients, they exhibit some form of LUTS or bladder dysfunction, and in men, if diabetes is there, then it accelerates LUTS severity, which is equivalent to 12 years of aging. So if somebody is of old age and having LUTS and having diabetes, then the severity will be much more as compared to the non-diabetic counterparts. This is one of the data from the Western country where they have tried to find out how many percentage of healthcare professional and patients they are aware they have got a knowledge related to this lower urinary tract dysfunction in the diabetes. So 88% of healthcare professionals were aware that LUTS is highly prevalent in diabetic patients, but only 90% they routinely inquire about the symptoms. And the same holds true for type 1 diabetes and type 2 diabetes. In type 1, only 55% they know. In type 2, 71% they experience LUTS, but only 1/3 of this they talk with doctor about their symptoms related to lower urinary tract dysfunction. And age is the single most factor which is associated with more severe form of LUTS. It is a multifactorial pathophysiology. There is a role of urothelial receptors, particularly muscarinic and P2X3 receptors, which can contribute to hypersensitivity. There is neurogenic affection, axonal transport deficiency, reduced nerve growth factor in dorsal root ganglia, and there is myogenic factor where hypertrophy due to polyuria, which is because of altered calcium handling and gap junctions. So initially there may be hypertrophy, increased sensitivity. Later on, the sensitivity will go down and the classical neurogenic bladder or the paralyzed bladder, silent bladder, that will come up. So if we see the clinical manifestations, it is quite heterogeneous. In the earlier stage, there will be an overactive bladder phase, and later on there is an underactive bladder phase. So overactive bladder phase is mainly associated with storage symptoms. There will be urgency, frequency, nocturia, and urge incontinence. Later on, as the neuronal activity goes down and the underactive bladder phase starts developing, there will be hesitancy in starting urination, weak urinary stream, sensation of incomplete emptying, overflow incontinence, and ultimately urinary retention that will take place. And if the men who are having diabetes, if they are also having benign prostatic hyperplasia, then that will further accelerate the LUTS progression. So men having diabetes and BPH, they are at much higher risk of LUTS as compared to those who are having BPH without diabetes. If we go for diagnostic algorithm, I think patient history is must, duration of diabetes, presence of other complications, they are to be checked. Glucose control is must to monitor. history of recurrent UTIs. If it is there, then it is a red flag. It gives you an idea there is some problem with urinary bladder and they require further investigations and sometimes urology referral. Sexual dysfunction, if it is present, then there is a high correlation with LUTS. So those who are having sexual dysfunction, you have to inquire for the symptoms of lower urinary tract dysfunction also. And there are various scoring tools which are available, which give you an idea whether the patient is having significant lower urinary tract related symptoms or not. The most common use is International Prostate Symptom Score, that is IPSS. If it is 0 to 7, then it is a mild. Moderate is 8 to 19 and severe is 20 to 30. By anybody having more than 8, you need to go for further testing. And there are various other scoring tools which are available. I will touch upon them in subsequent slides. Physical examination, particularly per-rectal examination in men and pelvic examination in women, perineal sensations to look for peripheral neuropathy and autonomic neuropathy, and in addition to the routine tests, urinalysis, renal function and electrolytes, they are must to be done in anybody who is having lower urinary tract dysfunction. These are the various scoring tools. If you see, this is International Prostate Symptom Score, which is for literate persons. If somebody is illiterate and not able to understand, there is a pictorial of this same prostate symptom score, and that is visual prostate symptom score. You can show them these pictures and you can calculate the score, and that is also being considered equivalent to International Prostate Symptom Score as far as validity regarding LUTS diagnosis is concerned. These are various international consensus on urinary incontinence questionnaires. Variety of questionnaires are available. Depending on the condition, symptoms, you have to follow that kind of questionnaires, both full form and short form. They are available, and all of this, they are validated globally across the countries. This is one of the forms of that ICIQ questionnaire. There are 14 questions and each question has got two parts. First is related to the problem itself, and second is related to whether that problem is having an impact on their quality of life or not. And depending on that, you calculate the score, and then you will be able to identify whether the patient is having moderate or severe symptoms and require further assessment or not. As far as evaluation is concerned, I think ultrasonography is the first thing to do, to look for mainly the bladder size, the bladder wall thickness, whether there is any other abnormality or not, the kidney size, whether there is hydronephrosis or not, and the important thing here is post-void residual urine. If it is normal, less than 50, and if it is more than 100, then it is suggestive of either diabetic bladder dysfunction or there is some obstruction, and this is a risk factor for UTIs. And particularly if you want to start your patients on SGLT2 inhibitors, particularly elderly people, you have to be very careful. If they are having post-void residual urine, then the risk of UTI will go up. You have to be very cautious while prescribing SGLT2 in this category of patients. The second non-invasive evaluation is uroflowmetry, which can give you an idea about whether there is a weak detrusor or whether there is an irritability of the detrusor muscle, which can be identified with the help of uroflowmetry. Then comes the invasive evaluation, which is the gold standard, that is urodynamics, which can give you an idea about either it is a sensory impairment or hypocontractility or hyperreflexia, and that will give you a proper diagnosis of the bladder dysfunction in diabetic patients who are experiencing lower urinary tract dysfunction. So this is one of the data from Western countries where men with diabetes who presented with bothersome LUTS, and then they were subjected to urodynamics, and at the same time they were also screened for autonomic and peripheral neuropathy, and they tried to find out what are the urodynamic findings and what is the association between diabetic cystopathy and autonomic and peripheral neuropathy. If you see the urodynamic studies, they show impaired first sensation. First sensation appeared only when the urinary bladder volume was more than 250 ml. That was in 23.1%. Increased capacity more than 600 ml in 25% of individuals. Underactivity in 78.8%. overactivity in 38.5%, high post-void residual urine in 65.4%, and that is also more than 1/3 of capacity, and bladder outlet obstruction as per this scoring system, that is 28.8%. And they also concluded that a large proportion of these patients, they have electrophysiological evidence of neuropathy, and if there is an electrophysiological evidence of neuropathy, then it can moderately predict the presence of cystopathy also. So if your patient is having significant neuropathic symptoms, do inquire for LUTS. It is likely to be there, and most of the patients, they will not report these symptoms to you. As far as management is concerned, I think glucose control is must, because we all know that there is evidence to support that proper glucose control, intensive glucose control in the initial years may prevent the development of retinopathy, nephropathy, neuropathy as per the DCCT EDIC data. But EDIC has got a cohort where they have done urodynamic studies in those category of patients. So there is a Euro EDIC. DCCT and follow-up is EDIC, and in EDIC also there is a small group of patients which were subjected to urological evaluation. That Euro EDIC study failed to show that the tight glucose control will reverse established LUTS in men. So once it occurs, it is going to be there, but the severity of symptoms may improve with the help of a good glucose control. I think Dr. Ajoy Tiwari is going to talk more about this. Lifestyle modifications, weight loss will help in reducing incontinence. Fluid management is very much required if somebody is having nocturia or increased frequency, and bowel regulation is also must. There are some form of behavioral and physical therapies which can help. There is time voiding, emptying bladder every 3 hours by the clock, not by urge, that will help. Double voiding and then waiting 1 minute and attempting again to avoid the residual urine, that will reduce PVRU and that will reduce the risk of UTI. Pelvic floor training, particularly in women, postmenopausal women, and credit maneuver, this can help in improving the symptoms which are related to bladder dysfunction. As far as pharmacotherapy is concerned, I have already highlighted there are two phases. First is the overactive bladder phase, where the symptoms are urgency, frequency, and hyperreflexia. Here you can use either anti-muscarinic agents like solifenacin, dorifenacin. These are the agents which can help in improving the symptoms, but you have to be cautious because they may cause silent urinary retention. So you have to monitor PVR when the patient is on solifenacin and dorifenacin. And there is large cohort data nowadays which says that it may have some impact on blood glucose also. So you have to be cautious while using these agents. Then there are beta-3 agonists which help in relaxing detrusor during steroids, and that will help in reducing these overactive bladder phase symptoms. They have got a safer side effect profile. It is mirabegron which is available, which is a newer molecule being used by urologists for management of overactive bladder. And lastly, there is intravesical injection of botulinum toxin for refractory overactive bladder. For underactive bladder phase, I think the thing which we are using commonly in our practice, that is alpha blockers, tamsulosin mainly, standard of care, relaxes smooth muscle to facilitate emptying. PDE5 inhibitors, they are coming in a large way, particularly in people who are also having erectile dysfunction. They improve erectile function also, and they have also got evidence to support they improve perfusion and bladder neck relaxation occurs. So they also improve LUTS related symptoms. And cholinergics, they are still not recommended because of the multiple side effects which are there, but they can be used if the patient is having urinary retention and impaired contractility. These are the advanced and surgical interventions: clean intermittent catheterization, particularly if nothing works, sacral neuromodulation, and TURP, particularly if the patient is having significant prostatic enlargement. These are the newer upcoming therapies which are targeting either inflation or nerve growth factor or other potential pharmacological agents like RAC1, AT1 receptor antagonists, and multiple other things, stem cell, neuromodulation. Everything is being tried in this category of patients. So to conclude, I will say DBD is a spectrum. It is not only the neurogenic bladder. It may start with an overactive bladder phase, and later on it may turn into a silent bladder, lazy bladder, or neurogenic bladder. Screen early, use IPSS and post-void residual urine in the diabetic clinic. Prevalence is quite high. People will not report it. You have to ask for it. And those who are having neuropathy, autonomic neuropathy, they are having higher chances of having this. Tailor treatment according to the urodynamic phase, that is storage versus voiding before prescribing, and protect the kidneys. Refer to urology if post-void residual urine is more than 100 ml, recurrent UTIs or hematuria. Thank you very much. Again, I thank Diabetes India team for this excellent session on diabetes and MRG.